Hello to everybody. Greetings from Dr. Sadhana Gupta. I'm Dr. Sadhana Gupta, who has served FOXY, South Asian Federation of Gynae and FIGO in various capacities, in various positions. And I'm your FOXY presidential candidate election year 2032. I bring greetings and I owe a big gratitude to all OB-GYN fraternity, pan-India, across India, who has been always together for so many initiatives for safe motherhood publication conferences. And this is my alma mater, SN Medical College, Agra, and my karma bhubi is Buddha, and who says we can never obtain peace in the outer world until we make peace with ourselves. And it is true with the pre-eclampsia disorder also, while we are managing this like turbulent disorder, obstetrical disorder, we have to be very cool and composed. And let's join hands to saving mother and giving quality obstetrical care to our women. Somehow the observation of the older gynecologist generation have been very, very sharp. So this is the observation from Pritchard, who says, in some way, chorionic villi induces vasospasm and hypertension, and we need to remove these chorionic villi if we want to get the woman well. And this is a so much a golden statement. And toxemia of pregnancy, pre-eclampsia, eclampsia, hypertensive disorder in pregnancy, and now gestosis. There are various names for pre-eclampsia because it is a disorder which is difficult to understand. Why it is so important to discuss? Because pre-eclampsia contribute to a major share of maternal and neonatal criticality and the mortality. While the hypertensive disorder of pregnancy affect around 15% of all obstetrical women, pre-eclampsia constitute around 3 to 5% of these hypertensive disorder of pregnancies. And it contributes to 10 to 15% of direct maternal death globally. And where the women are in low resource countries or in a low resource regions, they are more at the higher risk of developing pre-eclampsia as well as the pre-eclampsia related complication. So this is an issue where we really need to go into the intricacies and complexities. What in India, in right 2017, we lost around 35,000 mothers due to hypertensive disorder of pregnancy. The second important thing is that it is going to rise because of changing obstetrical demography. We are having more obese women, more women with metabolic disorder and comorbidities, and they are more prone to develop the HDP and pre-eclampsia. It has a not only short-term consequences, but the long-term consequences. Yes, short-term complications are abruptio, coagulopathies, cerebrovascular and the cardiovascular complication, which are the critical illness in the hypertensive woman in pregnancy, but they also put the mother and fetus for the long risk complication as well, because these mothers develop more hypertension, more diabetes, and the fetus is also having the risk of long-term complication. Now, coming to that is our part. When we say that it is hypertensive disorder of pregnancy, now it is a very simple question, but actually it is a very intriguing, because many people have their different observation and professional bodies are also sometimes not on the same page. I wish to give this one very, very important message. Whenever there is a systolic blood pressure more than 140/90, which is taken in with the due care and the protocols. This is very, very important. Then we term that this woman is having hypertensive disorder of pregnancy. Now, how to take blood pressure in a pregnant woman? Always take in sitting or left lateral position. So sometimes you don't take the blood pressure in lying down position because blood pressure reading will be futilely low because of the venal cable compression, with the appropriate size cuff. So please have the 2 or 3 size cuff in your OPD so that obese women and overweight women get the appropriate size cuff with the calibrated sphygmomanometer, and you have to confirm the reading after 2 to 3 hours with the second reading. So the taking right blood pressure measurement in a obstetrical population is very, very important. And this simple thing need your careful observation as well as the things to be ready in your OPD. So be careful and be careful with the way of measuring blood pressure and be careful with your interpretation. Now, these are some gray areas. Many people says that only I get blood pressure high at your clinic and not at my home, which is called white coat hypertension. Delta hypertension is sometimes there is a sudden rise and otherwise the blood pressure readings are normal. And masked hypertension, when the patient takes like a home monitoring, they have 4 or 5 reading normal, but 1 or 2 reading higher reading. So are they futile? Are they benign? I want to give one message of caution that the people who have the occasional rise of blood pressure, be in clinic, be at home, be at some point like some tension or something, these women are also prone to have the hypertensive disorder of pregnancy, which can be frank in next 1 or 2 months. So any high reading of the blood pressure more than 140/90 in obstetrical population to be taken with care, and to be, these women need follow up very, very closely. A second important thing is that as an obstetrician and clinician, we have to understand the difference between early onset preeclampsia and the late onset preeclampsia. So early onset preeclampsia is usually before 34 weeks of pregnancy. It is typically fetal disorder, which is due to the faulty invasion of trophoblast of the spiral artery, and it is associated with the IUGR, less volume of placenta, abnormal Doppler indices, and these patients are having more adverse maternal and neonatal outcome. While the late onset preeclampsia is the proteinuric hypertension which occur after 34 weeks of pregnancy, and it is considered the maternal disorder. That is a maternal response to the pregnancy because of underlying constitutional factor like patient is overweight, diabetic, and it is associated with a normal placental volume, normal indices, Doppler of indices, and they have more favorable maternal and neonatal outcome. And early onset preeclampsia is considered one of the severe manifestation of preeclampsia. Now, how to diagnose? The second thing, that how to differentiate between the hypertensive disorder of pregnancy to preeclampsia. So be very, very clear in your clinical practice. Gestational hypertension is the hypertension which is developed after 20 weeks of pregnancy, but not associated with proteinuria and not associated with any organ dysfunction. Preeclampsia, which we are discussing today, is the hypertension with proteinuria. But if the proteinuria is not there, but organ dysfunction is there, then also we term it as a preeclampsia. Chronic hypertension, when the woman was hypertensive before 20 weeks of pregnancy and after delivery, the high blood pressure continues. And if you examine these patients sometime only in second trimester, first time, it may be the normal, but because you missed the thing in the first trimester and before reading, and because of physiological vasodilatation patient, you can miss these women with the chronic hypertension. The chronic hypertensive women are also more prone to develop preeclampsia, then it is called superimposed preeclampsia, and eclampsia when there is a neurological either coma or convulsion associated with preeclampsia. So we have to be very clear in our clinical practice that how to differentiate between chronic hypertension, gestational hypertension, and preeclampsia, and then the complicated thing. This is the, again, to emphasize that proteinuria is one of the very, very important criteria for diagnosis of preeclampsia. But if it is not there, but the organ dysfunction or the IUGR is there, then we also consider it as a preeclampsia. Now, how to test for proteinuria? So the conventional teaching is 24 hours urine excretion more than 300 milligram per deciliter. But as a clinician, we know that this 24-hour collection is sometimes it is not feasible for the woman or for the nursing staff. The second option is the stat protein creatine ratio 0.30 milligram per ml. And the urine dipstick remains with us at every time, at any time. though there is an issue of a false positive and false negative. But for all practical purposes, this is a very important test for diagnosis of preeclampsia. And when it is 3+, it crosses the limit of the 300 milligram per deciliter, it corresponds to this. And if it is 4, then it is more than 1000 milligram per deciliter excretion of the urine, so of the protein. So this is the urine dipstick, because any person can do it, your nursing staff, at any moment of time you can do it. And this is important, practical, simplest investigation which we can have for the diagnosis of preeclampsia. But what we say that the ISHP 2018 recommendation, that is the International Society for Hypertensive Disorder of Pregnancy, which have given a very realistic recommendation that it is either de novo hypertension after 20 weeks of pregnancy with proteinuria and or evidence of any organ dysfunction. So it is affecting kidney, or it is affecting liver, or it is having neurological ominous sign, or the coagulopathy, a low platelet count, then we term it as a preeclampsia. And usually the preeclampsia with which the disease which can be a progressive. So life is a sequence and preeclampsia is also a sequence. Now, this is very important slide which says that what is severe and non-severe preeclampsia. So the BP reading more than 160/110, then it is a severe manifestation. If the woman is having ominous sign, that is headache, visual disturbance, upper abdominal pain, then it is a severe form. Patient is having oliguria or convulsion, of course it is a severe form. Or if it is a creatinine more than 1.1, thromboplatelet count less than 1 lakh, and the elevated liver enzyme level, or the IUGR, and the early onset preeclampsia. So these are all called severe manifestation of preeclampsia. Yet in coming slide, I will emphasize that every preeclampsia, for whatever degree, should be taken very, very seriously, because this is a disease which is spread like a fire across the all organs, and we have to be very, very vigilant with our protocol. And we have to understand, still we have failed to understand that actually in different women, what factor caused preeclampsia and HDP. But I will share few important etiopathogenesis which we have understood till now. So the one of the most important parameter or the cause for the preeclampsia or HDP is the inadequate maternal vascular response to placentation. So trophoblast is not able to have that the dilatation and the invasion of the spiral artery, and that cause the impaired hypoxia. And this hypoxia causes endothelial dysfunction all over the body, abnormal angiogenesis, exaggerated inflammatory response, and that has caused the cascade of the coagulation abnormalities. So it is start with the fetus maternal interface, and there is a maternal reactions in all over the vascular bed, and it affects thus every organ of the body. And we have to explain to our clinical practice to our patient that this is a disease which you have to take very, very seriously, and you have to come for a close follow-up. Few new concepts in understanding of preeclampsia have evolved, and one is acute athrosis, which says even without the poor remodeling, there can be preeclampsia because of the chronic vascular inflammatory stress, which may cause acute athrosis and further cause the endothelial dysfunction. So for the teaching purpose, we say that the preeclampsia is a two-stage procedure. First stage is the shallow invasion of trophoblast, so the inadequate modeling of spiral artery. And the second stage is the maternal response to endothelial dysfunction and all imbalance between angiogenic and anti-angiogenic factor. Important part is for this clinical practice is that the second stage we can really modify if we treat the patient clinical profile like diabetes, obesity, cardiovascular disease. If we say that the optimized your body weight, BMI, and the weight before pregnancy, optimized diabetes management before pregnancy, then we can have this second stage amelioration, and the woman, though she is having the shallow invasion, she may not have that form of preeclampsia. Yet for clinical practice, actually, again, it is an ongoing process and it presents clinically as a spectrum of worsening disease. Few interesting things which we want to know about preeclampsia, that the fetus is not a requisite. Even with vesicular mole, we can have preeclampsia. Even with secondary abdominal pregnancy or ectopic, we can have preeclampsia. Genetic predisposition has come in a big way in last 10 years when we have understood the genetic basis of many diseases, and they say a complex phenotypic expression is there with the genetic predisposition, and again there is a role of epigenetics and lifestyle modification and preconceptional care. And it is also very interesting to note that the fetal genes also control the maternal response and to the pregnancy, and the fetal gene can only also be responsible for development of preeclampsia in particular women. So it is an endothelial disorder. We can have capillary leak, so we have ascites, edema, ARDS, fetal growth restriction, so we have the IUGR and the oligohydramnios, and a spectrum of abnormal lab tests. In some liver, kidney, every organ is affected, and in some 1 or 2 organ is affected. And still we don't know actually what is the exact etiopathogenesis of preeclampsia, and there is a lot of research gap till now. This is another very important and interesting breakthrough in understanding of preeclampsia, that from that time, like since we have understood this preeclampsia, we say that it is an abnormal invasion of trophoblast of the spiral artery. But this theory says that it is a suboptimal cardiac performance by women to pregnancy. So the patient, the placenta is not a villain, but it is a victim, because the cardiac performance of pregnant women is suboptimal, either due to the inherent cardiac dysfunction or when the demand is more, like in the twin pregnancy or in the obese woman, then there is a subfunctioning of the heart function, and that lead to the suboptimal invasion of trophoblast of the spiral artery. So this is again a breakthrough in our understanding, which explains many things in the preeclampsia. Now the third question arises, that there is a lot of education and a lot of papers that can we predict and prevent preeclampsia. So I will like to give a very clear messages to all. Important thing before we just switch on and just order very costly and time consuming investigation, which is not feasible for a large majority of chunk of our patients, I will emphasize that see for the maternal clinical profile and measure blood pressure in all women. This will predict the preeclampsia in around 70 to 75% of women. The next is the PLGF and the uterine artery Doppler, and you can consider for high risk women like IVF pregnancy, elderly age pregnancy, but for universal, the maternal clinical factor and mean arterial pressure to be taken. Then the biomarkers, that is the placental growth marker, and if you are doing the biochemical screen in the first trimester, then the low value of PAPA is also predictor that this woman can have the preeclampsia. So something for all, and I will like to emphasize that Indian chapter of Gestosis has created a beautiful clinical score. In this, there is all existing and emerging risk factors are enumerated, and score is allotted 1, 2, 3. It is a simple tool you can download from the Gestosis website or the Gestosis link, and there is an app also, and in 70 to 80% of women you can predict that this patient can have the chances of preeclampsia. A lot of issue, again, I think we say that what are the biomarkers. So SFLT1 is the anti-angiogenic and placental growth factor is a angiogenic. So the women who are trying to develop preeclampsia will have low PLGF level and high SFLT1 level. The importance of this SFLT-PGF ratio is that it is relevant in second trimester also, and it predicts with the quite around 90% certainty that in next 7-15 days or in this next month, women can develop preeclampsia. Now, I want to emphasize this thing that when you order this patient, you must know why you are ordering it. This test is emerged because if we have the patient is having the low high SFLT and low PLGF, then you have to transfer the patient to the high risk obstetric unit. But if you order the test, but we are not like organizing any obstetrical care to patient, we are not giving any guidance to the patient, then it is not that useful. So the maternal clinical factor and the blood pressure measurement remains the important say in the prediction of the preeclampsia for the large number of clinicians as well as the obstetrical population, and it is effective up to 70 to 80%. If you add uterine artery Doppler or the placental growth factor, then it adds to 90 to 92%. Now, when you have seen that this woman is having high risk due to the blood pressure reading or due to the clinical setting or compromised uterine artery Doppler, what next? If you don't do anything, then actually no test have got any value. So aspirin is our aspirin is a thing which we have only to prevent the severity of preeclampsia or prevent preeclampsia altogether. The dosage can be 75 to 150 milligram, give at night and start at 11 to 14 weeks, preferably before 16 week to 36 week of gestation. How aspirin it by inhibiting cyclooxygenase and the prostacyclin thromboxane, that is the angiogenic and anti-angiogenic, that balance is restored, and it is this cyclooxygenase inhibition is dose dependent and cumulating with repeated dose. A second important preventive measure is the calcium supplementation, and it is been studied in the global many studies in low, poor, middle income countries, that when we supplement 1500 to 2 gram elemental calcium per day after 20 weeks of pregnancy, especially in women who are having low calcium intake and diet, they have the preventive role in the preeclampsia development. So should we recommend aspirin to all? Answer is no. You have to assess the risk factor, which can be high or the moderate risk. So again, this question that yes, we must know that what is the severe manifestation of preeclampsia, but any point of time, the mild preeclampsia can turn up into the severe preeclampsia, and every clinician should be aware of this, beside knowing that what are the severe manifestation of the preeclampsia. So ISH says that don't classify because we don't identify. Now, why we are so much considered for the prediction, for the prevention of preeclampsia? Because this disease can be life-threatening. We can have acute maternal complication, pulmonary edema, myocardial infarction, stroke, ARDS, coagulopathy, renal failure, and the intrauterine fetal death, and the all IUGR and the birth, the fetal hypoxia. So there can be any time, it is a progressive disease, and when we should be alert, because whenever there are signs that it is progressively deteriorating, then we have to act very aggressively. The fetus is the most effective person affected, like living body, in this preeclampsia syndrome. We can have short-term complications which we observe in our obstetrical care, that is IUGR, oligohydramnios, sometimes sudden abruptio and sudden IUFD. Then the preterm birth, because we want to terminate pregnancy with low ABGOR score, need for NICU admission, and more chances of non-reassuring fetal heart rate, and of course then cesarean section. The baby can develop the long-term complication also: cerebral palsy, low IQ, hearing loss, visual impairment, and in the long run, in adult life, they are more prone to develop the metabolic disorder. So the good management of the preeclampsia affect not only mother in short and long term, but it is closely linked to the generation next health. And here is the obstetrician role in a big way in making our country healthy. And what we say, ISHP again and again warm that especially in low resource setting, in low and middle income countries, treat every preeclampsia as a important complication, treat aggressively any form of preeclampsia. Now, how do we want to manage this preeclampsia? The important points are what is the severity, what is the gestational age. Sometimes we really cannot diagnose it definitively because it comes in various presentation. But whenever you suspect that this patient can develop HDP and preeclampsia, first thing is close and close surveillance. You have to emphasize in every visit to woman, her husband, her family, that of course you need to come more frequently for the blood pressure checkup, for the more ultrasound, for the lab investigation, and so they are mentally ready for everything. What we want to achieve in management, we want to achieve management timely termination with least possible trauma to mother and fetus. So this is very, very important. We want to have a healthy newborn, and we want to have the complete restoration of health of mother. And for this, the accurate estimation of gestational age is very, very important from first dating scan and the last menstrual period, because it is early versus late onset eclampsia, and what is the preeclampsia, and what is the right time to terminate the pregnancy. So we have healthy newborn, baby is not suffering from the extreme prematurity or IUGR. These are the important concerns in the management. So confirm preeclampsia first. So good blood pressure reading, and when the BP is high, you can admit the patient for daycare so that you can do all tests and you can observe blood pressure. So you confirm that it is a simple HDP or it is preeclampsia. You can hospitalize usually for 1 day, and you have to emphasize its importance to the mother and the family. And secondly, if they are not ready, then like organize that they have the regular blood pressure monitoring and they come report early for the every 3 days or every 7 days. So it is our job, never like throw the responsibility to the woman that they don't understand, but it is also our job to emphasize that what is important and where the woman is going. When we want to confirm what we want to do, detailed examination and scrutiny for obvious sign, weight measurement, urine quantification of proteinuria by dipstick or spot protein creatinine ratio, BP reading every 4 hours except when she is in deep sleep, complete blood count for the HB and the platelet count, renal function test, creatinine urea, and the liver function test. So I want to emphasize that all these are very, very simple and very, very less costly tests. They are not costly tests, but actually these are the simple tests which actually guide that when to terminate and what drugs we want to give to these patients. So uric acid, LDH, and coagulation studies are not required for most of the preeclamptic patient unless the situation is like abruptio or something the patient is having ominous sign. Then we require uric acid and LDH and coagulation studies, and neither Justosis, neither other professional organization advocate for universal testing of these tests. Fundoscopy sometimes we require because we want to differentiate between chronic and new onset disease. Now, fetal evaluation, how to do? First is the clinical, whether there is IUGR or the growth compatible fetus, then the fetal biometry, amniotic fluid, and the umbilical ultrasound. What professional body says that if the baby is not having IUGR, then the doctor studies are not actually beneficial. But if there is IUGR, then we have to go for the doctor studies, and especially the umbilical artery ultrasound, which can be taught and learned by anyone. Besides, always look for the placental location and morphology, that it is a normal size or it is a higher size or it is a less size as per gestational age, and if there is any evidence of abruptio. Because many times only we are focusing on the fetus and we really tend to miss very, very important information. This is when there is a preeclampsia with IUGR. Now this is the time to act very, very closely. This fetus requires support and observation, and umbilical artery doctor here comes in the way. So whenever there is a IUGR fetal weight less than 10 centile, it is a adverse prognostic past, and if it is fetal weight less than 3rd percentile and abnormal umbilical artery doctor, then it is a significantly increased risk of adverse reverse perinatal outcome. And that require our vigilance, obstetrician vigilance, ultrasonologist vigilance, that this fetus need very, very close follow-up. Now, if there is a increased resistance in umbilical artery, you start very, very close follow-up, that is weekly interval. If it is a absent and diastolic flow before 34 weeks, daily CTG, twice weekly ultrasound and AFI. And if you see the reverse and diastolic flow before 30-week gestation, this patient needs admission. Thrice weekly umbilical artery Doppler and AFI, that is the every other day, and the twice a day CTG. So if umbilical artery is absent and diastolic flow, don't take this baby more than 34 weeks. And if it is a reverse and diastolic flow, don't take this baby more than 30 weeks, because if you are going to prolong that the baby, there is more chances of the fetal hypoxia, long-term impairment, as well as the intrauterine fetal death. These are the few images you have to understand. I wish that every obstetrician should have a good machine for ultrasound and should have this skill of doing ultrasound. It is a very simple umbilical artery focusing, and when there is an absent, you can take decision at any moment of time, day, night, and you can take the baby out in the timely fashion. So this is about baseline maternal and fetal evaluation, and emphasize very, very closely to the important close follow-up for the mother and the fetus. And we have to again counsel the woman and the family. Ask for ominous symptom. Patient might not tell to us because they think it is a gastric pain, or sometimes in pregnancy we have the giddiness. Ask the patient, do you have headache? Do you have difficulty in vision? Are you having any pain in the upper abdominal pain? So we have to ask for ominous sign, because they will give the clue that this patient is going into the severe form of preeclampsia. And then you do the other test for again testing that where the disease are going. More profound these ominous sign and symptom are there, we have less time for the baby to carry on the pregnancy. So again, it is our Indian chapter of gestosis very, very nicely defined that the patient with persistent headache, blurring of vision, difficulty in breathing, feeling of ill, second trimester vomiting and epigastric pain, high BP, oxygen saturation less than 95%, and impaired liver and the kidney function test and the platelet count. These are the ominous signs, and they need urgent and prompt management. So be very, very alert in it. Why we need additional imaging beside ultrasound? Maternal echo when you suspect that there is cardiovascular complication, chest x-ray when you suspect any pulmonary complication, MRI or the neuroimaging when the patient is having refractory seizure, or patient is coma, or patient is confused. Sometimes it is needed. It is only at depending on the clinical situation. So again, we have to be very careful about the ominous sign, about the lab test and the fetal evaluation. And again, we say that it is an ongoing process. In some women, it is halted at one floor. At some women, it is affecting every organ. So we have to be very, very careful. Though there is a difference between low resource and high resource. Why it is important that in India, when we do conference and education, we listen so many high-fi things, which is actually not practicable, and obstetrician all over, like in the many times say, oh, yes, they are telling, but we can't do it. And it gives them a low sense of self-esteem and confidence. But I wish to emphasize that with the simple test which we have discussed, with the simple tools to predict the preeclampsia, and with the simple tool to evaluate, we can really avoid the life-threatening complication of preeclampsia. So for under-resourced countries, settings, we have a lot of things to offer to our women. A second important thing is that we don't want to have the life-threatening complication like eclampsia, like intrauterine fetal death, like acute kidney injury. We have to intervene in between what is given in the second table. We have to identify the complication before the life-threatening complication actually present to us. So like identify when the woman is having visual symptom, not as the eclampsia. Identify when the patient is having impaired serum creatinine more than 1.5, more than uric acid, not as the acute kidney shutdown. And identify the woman when patient is having upper epigastric pain and impaired liver function, and act at that level. We don't want the life-threatening complication, which is the financially, emotionally, every time, and the prognosis is also bad. So that is the like a paradigm shift in the mindset of every obstetrician and every obstetrical care setting. So this is the way to change, because we want to optimize the health of our mother in our country. When we have all these things, the abnormal fetal, like IUGR or something, all these things, when they happen, we have a very little time and we have to terminate the pregnancy. Now, coming to specific points, what is needed for the management of preeclampsia. So seizure prophylaxis. So one thing important that we must know and we must practice, that the magnesium sulfate is the best drug which has been proven to prevent seizure. And the other thing like the 14 and the lytic cocktail and the other epitoin, they are not considered as a first choice. They are always a second choice when the Maxel is not like effective, or sometimes it is the patient is refractory to the initial line of treatment. So keep belief on the Maxel, and whenever there is a preeclampsia and the severe manifestation, you give Maxel prophylaxis, and the dosage is the loading dose, that is the Pritchard regime. We advocate that is the 4 grams slowly, and it is 24% solution. So always keep 1 gram per ml Maxel vial. Don't keep 0.5 milligram, 5 milligram per ml vial. So 4 gram plus 8 ml normal saline. So it comes like 4 gram, 8 ml volume, then the 12 ml normal saline or distilled water, which makes 20% solution. That give IV. Then the 10 milligram this Maxel intramuscular be given. So it is total 14 in alternate buttock, which is followed by 5 milligram intramuscular in alternate buttock in 4 hours. Or you give the 5 ampule in 500 ml ringer lactate and give this bottle in 5 hours. So it is 1 gram per hour. So it is very simple. It can be done. Still, we have seen that the people are hesitant to give Maxel, because especially in single person nursing home, in the primary health center, they are afraid of Maxel. So if you are really afraid, you can have your own protocol. So you omit IV1, but you give the whole intramuscular regime. But important thing is that maintain protocol for your institution, that Maxel is to be given for every patient with the severe manifestation of preeclampsia, where you consider that woman is going to deliver within 1 to 7 to 10 days. You don't have to do the magnesium level for the Maxel prophylaxis. You have to see only clinically, and if the patient is having patellar reflex, urine output less than 100 ml in last 4 hours, and the respiratory rate is more than 16 minutes, you can give the subsequent dose. But if it is not there, then you withheld the Maxel further dose, give oxygen. Sometimes the patient can have respiratory depression, then intubation, and antidote of Maxel is the calcium gluconate. So this is very important, that believe on Maxel. Make institutional protocol that every woman with preeclampsia receive Maxel, which is beneficial to mother as a seizure prophylaxis as well as to neonate. The second important thing is the antihypertensive regimen. So first question is when to start antihypertensive. So I will give clear message that when it is 136/85, start thinking of giving antihypertensive, and for sure when it is 140/90%. 140/90 millimeter of mercury. What is AVA? We don't to have 110/70 or 120/80 millimeter. We want to reduce blood pressure around 50% to 20%, 25%. And for this, we need antihypertensive agent, which are rapid onset of action and the short duration of action. So if there is a sudden lowering of blood pressure, it is short acting and it does not detriment the mother and fetus. Why we want to treat hypertension? Because around 20 years ago, we say that for fetal compromise, we start blood pressure antihypertensive after 150/90 or 160/100. Because we have learned with this experience that if the woman is having severe hypertension that is more than 150/100, patient is more prone to have the life-threatening complication like congestive heart failure, myocardial ischemia, renal failure, ischemic or hemorrhagic stroke. And now the very, very important message that after 136/85 millimeter of mercury, be very, very careful. In high-risk patient, you start at this reading, 136/85. But when there is a reading 140/90, confirmed with the two reading 4 hours apart, well taken, then it is time to start antihypertensive, and we want to maintain blood pressure below 140 and below 90 millimeter mercury, 140/90. These are the drugs what we have: hydrogenate, lobetalol, nifedipine. Out of this, lobetalol and nifedipine we have for availability in our in our system. Hydrogenate sometimes in some institution, but it is not universally available. So lobetalol IV 10 to 20 milligram, take blood pressure after 15 minutes, then 40 to 80, maximum 300 milligram. Lobetalol, when there is a bradycardia, don't choose lobetalol. Nifedipine, you can give 10 to 20 milligram orally, repeat in 20 minutes, maximum 180 milligram. If it is tachycardia, and sometimes patient have the real throbbing headache after nifedipine, which actually frighten us because severe headache is a ominous sign for the severe preeclampsia also. So you have to choose your drug well, and you have to optimize the doses. Don't afraid that, yes, we have given the 20 milligram TDS, that is 60. You can give up to the 180 milligram. So this is very, very important that optimize your antihypertensive drug and understand every drug. What antihypertensive not to be given, because sometimes we see, especially in court, sometimes that the obstetrician refer the patient to physician, and they are very fond of ACE inhibitor and angiotensin receptor blocker and sometimes diuretic. So we have to have a close meeting that ACE inhibitor and angiotensin receptor blocker are contraindicated in pregnancy because they are teratogenic in first trimester, and after second trimester, they can cause IUGR, fetal renal dysfunction, and oligohydramnios. Diuretic to be avoided also because it also reduction in the maternal blood volume in already the low intravascular volume in the preeclamptic woman, and it can lead to fetal electrolyte disturbance. And the beta blocker, except lobetalol, and calcium channel antagonist, except nifedipine. So we must know what antihypertensive drug not to be given, and it is to be tapered even in the preconceptional care if the patient with the chronic hypertension was on these drugs. Coming to the what can be the life-threatening complications. So when you see the patient with eclampsia, with the convulsion, what is our first priority? Teamwork, call for help. We need a good facility, but every patient needs first aid treatment. So first look for airway, lateral decubitus position, mouth gag, neck extension, but don't put that mouth gag too low, otherwise it will cause gag reflex and resultant vomiting and aspiration. Give oxygen 5 to 10 liters per minute by the face mask and look for the oxygen saturation. We want to have oxygen saturation more than 96%. And if oxygen saturation is less than 92%, suspect that patient have already aspirated or there can be pulmonary edema. And these women need arterial blood gas analysis, and we want to prevent respiratory hypoxia and respiratory acidosis. Check for circulation. You have to give fluid. Crystalloid, that is ringer lactate, is a fluid of choice. I mark, don't give 5% dextrose, don't give 5% dextrose NS, and the fluid has to be restricted. That is 65 to 80 ml per hour. So 1 point of the ringer lactate to be given around 4 to 5 hours, and always catheterize these patients with eclampsia. So supportive care, we must be very, very Our team, every member of our team should be tuned that when the patient with eclampsia comes, what we have to do: first, second, third, fourth, lateral position, suction, oxygen, check for his catheterization, keeping the fluid, and then the magnesium sulfate and the antihypertensive. Same magnesium sulfate, same dosage, and same antihypertensive drug. If the patient is having recurrent convulsion, you start two things. First of all, then if it is not refractory to the second or the third dose of Maxwell, then it is the time to use the second line drug, that is phenytoin or the thiopentol, for which we need the ICU care. Sometimes the patient need endotracheal intubation also. And the second point you consider in recurrent convulsion, or the patient is not coming out of coma, that patient has already developed some neurological complication, and these patients require CT and the neuroimaging. Another important thing, when the patient comes with eclampsia, you can have a very, very non-reassuring fetal CTG. Don't jump to do cesarean section to take out this baby. It is due to maternal hypoxia. And when you resuscitate the mother with Maxwell antihypertensive fluid, the things become normal, which you see in this CTG. It is a very bad CTG, but after maternal resuscitation, it has come to absolutely normal. So don't go for the induction of labor or cesarean in an unstable eclamptic patient. Do all the primary thing, do all the drug regime, and then you look carefully, assess what is Bishop score, patient is already in labor, what is the status of the fetal CTG, and then you plan that you want to go for induction of labor and for the possibility of vaginal delivery, or you want to do cesarean section. What about HELP? I will be quick in this, because HELP, we know it is a low platelet and the rising liver transaminase enzyme and the LDH, and we can have class 3, class 2, class 1, which is platelet less than 50. So one important thing, that the HELP is considered as a severe manifestation of preeclampsia. One thing what I say. Secondly, when the patient have this low platelet count, you have to follow platelet count every second to third day. And you must know what is the course. There is a 40%, 25 to 40% decrease platelet count every day. And the peak trough can occur first 2 days after delivery. So don't think that just after delivery you are going to have a sudden rise of platelet count. And we have to have all supportive care, sometimes steroid, to increase platelet count, and the Maxwell and the antihypertensive drug. So when the patient is having this low platelet count and raised liver enzymes, this is the time that it is severe manifestation. Usually we don't have more than 3 to 7 days of the prolongation of delivery, and they require close monitoring in the postpartum period. So HELP is a manifestation of the severe preeclampsia. Patient can have refractory convulsion, patient can have coma. So whenever there is a prolonged neurological complication, then you should go for the multidisciplinary opinion for the neuroimaging and other things. And if the aspirin or heparin was used, be proactive for any neurological complication. Subcapsular hematoma. Our role is to diagnose, to suspect the liver injury. So when in upper quadrant pain, there is a increase the impaired liver function, then you think that the patient might have the liver complication. You go for the imaging for the liver, for the upper abdomen, you confirm with the ultrasound, with the chest X-ray or CT scan. And if it is a subcapsular hematoma, it needs multidisciplinary unit. It is a life-threatening complication, require a lot of blood component and the laparotomy. And the issue is, our role is to diagnose well. Be very, very careful in transferring this patient. In today's scenario, one-person nursing home people should not admit the patient with eclampsia or the severe preeclampsia. So transfer the patient, give Maxwell, give nifedipine, write down that this was blood pressure reading and this has been given. Organize transfer with ascertaining that bed is available in medical college or in that hospital, and always escort the patient with one attendant, with one staff of your hospital staff who have the eclampsia kit, that is Maxwell and other drugs, during the way and with the oxygen in ambulance. So this good transfer protocol can save a lot of life if we organize a very good quality referral and a respectful referral system. Now, when to deliver, I have taken a little bit that it is on the fetal biometry level of the severity and the umbilical artery Doppler study. So the termination of delivery is good for mother in preeclampsia, but we want to have healthy baby. So we want to have the age of viability that is around at least after 30 to 32 weeks, so that we can have the healthy baby, which is healthy in the short term as well as in the long term. So it is the thing which I repeat, that if their blood pressure is controlled, that is late onset preeclampsia, the patient is controlled, no organ dysfunction, you can consider the gestational age, prolongation of delivery till 37 weeks. But in that period, you have to follow the woman for all the organ dysfunction, for all the fetal biometry. And whenever there is a deterioration of any value, we should consider the termination of delivery. Again, what we say that reverse diastolic flow, not more than 30 weeks. If it is absent diastolic flow, not more than 34 weeks. If omnious sign, you have to deliver. And when you want to plan the delivery, then give steroid and give Maxel, which anyway you are giving for the preeclamptic patient for a good maternal outcome, because Maxel has got the neuroprotection, especially when fetus is too premature, that is before 32 weeks of gestation. Always ensure that you conduct delivery or cesarean in a well-equipped hospital where we have not only the ICU care, good expert obstetrician, but also the good pediatrician, neonatologist, and anesthesiologist. This is very, very important. Nowadays we see everybody go for a quick cesarean section, but all evidence and experience says that we can opt for vaginal delivery in many, many cases. Of course, if you do induction much before the expected date of delivery, then the chance of cesarean are high. We have to keep the low threshold for the cesarean section, but in around 60 to 70% of women with preeclampsia, they can achieve vaginal delivery. And when the media is talking so much about high cesarean rate and the fingers are pointing towards us, we have to stick to the protocol for the timely indication. But cesarean section is preferred, yes, of course, when there is a severe FGR, growth restriction, reverse diastolic flow, obstetrical indication, major degree of cephalopelvic disproportion, then we have to have the low threshold for the cesarean section. Always give oral antihypertensive at the start of labor. Fluid should be restricted, and you have to give the Maxel prophylaxis if it has not been given. So fluid restriction is 68 to 80 ml per hour. This is very, very important. Anesthesia is another consideration. I wish to emphasize that the regional anesthesia is the safest for these preeclamptic women, because the general anesthesia carries more risk. Why? They can aspirate more, they are more liable to have failed intubation because of laryngopharyngeal edema, and there can be stroke because they have the sudden high rise of blood pressure during intubation and extubation. But when the patient is having low platelet count, the safe limit, what anesthetic association say, if it is less than 70 into 10 to power 9 per L, then the general anesthesia should be considered because of the hematoma, epidural hematoma, and the other coagulation problem. Maxel should be given for before preeclampsia, again surgery, because it has the seizure prophylaxis role. Always and always give the active management of third stage of labor. Anyway, every woman needs this active management of third stage of labor, but preventing PPH in preeclampsia is a very, very important and life-saving consideration. Give carbidocin, give oxytocin, and because when these patients develop PPH, they are not able to tolerate the large amount of crystalloid. We have to depend more on the blood component. And the second thing, there are many reasons that they are prone to develop atonic postpartum hemorrhage because of the Maxel and nifedipine, which are the atonic, which are the uterine relaxing drug, and the hypertension and endothelial dysfunction. If the baby is the IUGR, it is better that ward level we can do if the facility is available. And whenever there is IUGR, because we have the Indian national priority is the prevention of stillbirth. And we have a lot of research gap in this area. So better you send the placenta for the histopathological examination. You have delivered the baby, and many times obstetricians say very casually, once the baby is out, everything will be fine. I want to warn you very, very carefully and emphatically that the postpartum period in the pre-eclamptic patient can be very, very turbulent. Don't shift these patients to the ward, normal ward, before 72 to 84 hours, because these women are more prone to develop hypertensive crisis, neurological and respiratory complication just after delivery. And why? Because of the pain, because of volume retention, because of the direct vasoconstriction and low colloid osmotic pressure. Every staff should be aware that they have to look these patients with preeclampsia very closely. Don't remove their monitor for blood pressure reading, for PPH, for the respiratory breathlessness and the ARDS neurological complication. Measure BP at least 4 to 6 RD, their general well-being, because always patient have many, like 2 or 4 hours before she has a problem. But our staff, our nursing staff should be very, very well aware that these patients are more prone to develop the postpartum complication. Don't discharge these patients early. At least 5 to 6 days they should be in hospital. If the impaired organ dysfunction was there before delivery, then repeat day after delivery. Then after 3 days, antihypertensive drug should be continued or tapered slowly, and always don't discharge and prefer NSAID is not a very good choice in the pain relief for the preeclamptic women. So a short-term follow-up, then call them after a week, how their BP is going on, their BP is going down with antihypertensive or without antihypertensive, and then after 3 months and then 6 months. If they are having persistent hypertension and proteinuria, refer to physician, and always advocate lifestyle modification, because these women can have higher risk of preeclampsia and growth retarded babies next pregnancy. Advice on contraception, and if they follow good diet habit, salt less diet, optimizing blood pressure, optimizing their body weight, optimizing exercise, then this will be the permanent imprint of your care on the family and the health of that woman. And this is the time to take this complication into the opportunity. So life is full cycle, and pregnancy test women health status at many fronts. When the woman is first time pregnant, the woman's genetic, epigenetic, many things come in front of us. We as obstetricians are fortunate that we can intervene lifestyle and the medical intervention at young age. And when we manage this complication, we have the short as well as long term of health of not only women, but the generation next. I thank for active listening. Thanks for always being together. Devote time, treasure, and talent for saving mothers. We have been always together, and I seek your permanent connectivity and your support for my presidential candidature when the election will be held next year. Thank you very much.